What is telemetry monitoring? Telemetry monitoring is a prescribed intervention so that we can monitor a client's cardiac rhythm through a centralized station. How is it performed? The first thing that happens is that a specialized trained individual at a facility applies the telemetry monitor that gets programmed to the central station. So this is an example of a central station. This is an example of a telemetry monitor. You do not have to be a registered nurse to apply a telemetry pack if your facility has provided specialized training to a technician to do so. What's important is that we make sure we never delegate the education that goes along with the instructions that we should provide to a client who is going to be on telemetry. The telemetry monitor sends information wirelessly. So it receives information through these wires that are positioned white over right, smoke over fire, so the black, the red, the white. The precordial lead is brown with the green lead on the opposite side. It transmits the information it receives to the central station. Telemetry orders can include pulse oximetry with telemetry or without. So many times you'll see that there is a sensor for pulse oximetry. A monitor would be in a centralized location and would alarm if they exceed a certain rate or some dysrhythmia or irregular beat arises. When that happens, you'll see it starting to flash, and then it will generate a strip for further interpretation. A novice nurse would have to receive specialized training in interpretation of ECG strips to be a tele-certified nurse. What's important for your examination is that you will be responsible for interpreting some rhythms. But more importantly, you're responsible for identifying who should get telemetry care, who no longer requires telemetry care, and how do you provide nursing care for a client experiencing dysrhythmia. So that is considered part of the generalist nurse. Okay, so let's talk about the very first thing that I mentioned there. And the very first thing I mentioned there is who gets tele. So I'm pulling up an order set that I found on the internet that distinguishes who gets tele. So people who are appropriate to get tele are people who have had an episode of syncope or passing out, are hemodynamically unstable, or have very fast rhythms or very slow rhythms, okay, that are not sinus in origin. So here, a person with heart failure, V-tach, low blood pressure, heart block, low heart rate, or fast heart rate. They can also be on tele for specific types of heart blocks, atrial fibrillation. We also admit people to tele who are postoperative, who have cardiac risk factors that increase the likelihood that they could experience a concern. So that would be somebody who has unstable angina, new EKG changes, and has had a positive stress test. Whenever we give medications for the purpose of controlling cardiac rhythms that prolong the QT interval, it's important to consider having them on telemetry. Anybody that has a pacemaker that's applied to their chest wall, called a transcutaneous or external pacemaker, should be on telemetry. Clients who are experiencing acute coronary syndrome should be on telemetry or in the intensive care setting. And clients who are experiencing decompensated heart failure. Okay, typically we're looking at people who have risk for low heart rates and fast heart rates that are not sinus in origin, and people who've had procedures that place them at risk for dysrhythmia. And now we're going to learn about these procedures. People who have had a coronary cardiac catheterization or angiography could experience dysrhythmia. People who have had procedures where we have either done pacemaker insertion or defibrillator insertion, or have done some kind of mechanical or cardiac conversion or ablation, should be monitored for dysrhythmia. People who have severe electrolyte disturbances, and these are the big three: potassium, calcium, and magnesium. Those electrolyte disturbances should be monitored through telemetry. And clients who are experiencing drug toxicity that is associated with arrhythmia, those are good candidates for telemetry. Now let's take a look at what are some of the concerns that we have in providing that care. So if you go to your nursing procedure manual and you're at top and you hit Control F and you typed in telemetry, you'll see that you'll come to the telemetry policy. So if you're the nurse supervising your team on this floor, you'd want to make sure that everybody is competent to follow this policy. The first thing is that you have to be capable of screening for the appropriate clients to stay on your unit and identifying which clients are safe to be transferred off. So, people who should be on telemetry are people who have had EKG changes consistent with an acute MI, but they'll probably be in critical care. Changes in their EKG that are abnormal, but don't rise to the criteria for critical care monitoring. People who've had positive cardiac enzymes, either following up from their critical care experience. And when we say that, we mean a troponin greater than 0.5. 0.05, my apologies. We also look at the irregular beats. So the irregular rhythms that are a concern are atrial fib and flutter, a ventricular tachycardia or supraventricular tachycardia, so that meaning that it doesn't come from the sinus node, 5 or more PVCs, new onset tachycardia or bradycardia, or heart block. Now, I'm not asking that you know how to interpret or identify what they look like now, but you should be able to identify the terms if they have been described to you by the person who is looking and interpreting the centralized telemetry strip. There are certain medications that are, we call it pro-arrhythmic. So there's certain vasoactive medications like dopamine, dobutamine, Levophed, norepinephrine, that can cause dysrhythmia. And for that reason, they should be on a cardiac monitor. What we know is that we have documentation requirements and monitoring their care requirements. So essentially what the telemetry nurse will do is set the alarms when the client is admitted to alert them should they be experiencing a problem that requires intervention or medication. The other thing that the nurse would be responsible for is providing the patient education to include the client in notifying if they're experiencing symptoms that could be associated with dysrhythmia and how to report that to the nurse that is caring for them. Because they are telemetry patients, they must have IV access. If they don't have IV access and they have a life-threatening dysrhythmia, you're not going to be able to intervene. Many units will distinguish the types of alarms to set. We're going to focus on fast and slow. And so if or abnormal. If it starts to alarm, the first step is check the patient. because there are many reasons why the monitoring strip could not really reflect the true emergency of the client's situation. So we never treat a monitor, we treat the patient. And every time we go to check on that patient, we're looking for ineffective tissue perfusion, if they're having signs of a heart attack, or decreased cardiac output. Are they having signs of heart failure? That tells me if they're potentially unstable. When we have these rhythm changes, we are going to interpret them, document them, and report them. And we'll correlate to how stable they are. Again, it's important to check your patient when they're having this experience. And if they do not meet rapid response criteria, we put the call out to the cardiologist. If they meet rapid response criteria, we initiate ABCs and stabilize the client while we wait for rapid response to arrive. What's really important too is to remember your documentation requirements. So you will learn specific dysrhythmias that you might see on NCLEX, and we're going to learn to recognize the pattern of those dysrhythmias looking at a 6-second strip. And we know that the telemetry nurse is responsible for recording that information in the client's chart and monitoring how that changes over time. So that is routine telemetry protocols.